Well, it's a pleasure to be here, and it is sunny today, John. So it's a beautiful day to be hiking or golfing, which is what my daughter and husband are doing. And it's an honor to be here. This is my fourth or fifth conference, and the first time that I've had the opportunity to speak. So I'm really pleased to be here. I also wanted to acknowledge that there are some real experts in neonatal palliative care in the audience, Renee Boss and Suzanne Tost. And so there are other people that you could ask questions of. John actually inspired me. I was thinking about dumping my entire talk too, because I think there are some important points that have been raised this morning and will continue to be raised for the rest of the time. But I wanted to bring up some important points before I launch in. First of all, I am also a foreign delegate. I am from Texas. Secondly, I think that palliative care may not be what you think it is. It's really about the prevention and relief of suffering. And when we talk about only comfort care or withdrawing care and then offering palliative care, we're using words that beget certain attitudes and prevent appropriate referral to palliative care services. I think that palliative care, when you really understand what it actually is meets John's paradigm of tolerating ambiguity, and it is the true libertarian values that are applied here in palliative care. And I want to recognize that decision-making and deciding even where the gray zone is something that can't be totally defined ever, because it is dependent on individual values and how you apply them. And I don't believe that best interests can be defined by the patient alone. Virtually all decision-making ends up being in the family context. There's a spate of papers recently documenting that you can't just focus on the individual, even within our autonomy-loving Western bioethics circles. So I think we need to think about that. And I think informed consent as well may not be something that we're able to do effectively with words alone. Volandes published a beautiful paper in British Medical Journal in 2008 looking at decision-making by surrogates for people with dementia, and found that a 90-second video in which he showed a woman actually sitting in a beautiful garden setting with her loving daughter attending her and feeding her as she didn't understand who her own daughter was or how to eat effectively, dramatically shifted surrogates' decision-making about best interests for their loved adult. So I think we need to think about some of these issues as we explore the ideas of palliative care and ethical decision-making on behalf of those who can't speak for themselves. And I also wanted to acknowledge a few other experts in neonatal palliative care who let me use some of their material. So I'd like to be able to help you distinguish patients who might benefit from perinatal and neonatal palliative care and understand that we can integrate the conceptual framework of palliative care within the existing healthcare paradigms. And we need to be able to look at ways that we can do palliative care. There are a couple of papers in your notebook that really go into detail about how to implement this and how to think through the practical aspects of neonatal palliative care. As a critical care physician, I actually launched into palliative care and ethics inquiry because of my concerns of doing things to patients that may not be in their best interests, not only them as the patient, but the family more exactly. And I actually was a co-author on a paper that came out in JAMA in 1994 about, quote, withdrawal and withholding of care. I didn't really understand that term at the time, in the pediatric critical care unit. And we found that, as Annie described, that we often will continue to progress or push for, quote, life-sustaining measures on severely impaired children. And I think part of that is a parental self-definition that your job above any other is to preserve the life of your child. And people learn to adapt to severely terrible situations. There was an interesting paper about patients on dialysis, asking them about their own quality of life, and they rated it at an 8 out of 10, 10 being the best. Then they underwent a transplant, and then instead of having to spend 4 to 6 hours a day, 3 days a week on a dialysis machine, they were mobile and free, but they had to take handsfuls of pills. And they were asked at that time, well, what's your quality of life? And they said it was an 8. So the question was, well, as a dialysis patient, it seemed a lot worse for you, and now with this transplant, we felt like we did something good. We think, we're helping you and your quality of life should be better. And they said, well, when I was on dialysis, it was actually a 3, but that's what I had to live with. so that our conception of quality of life may be biased by what we are forced to endure, not because objectively it's an acceptable quality of life. So these parents that want their 7-year-old severely impaired child to keep going, maybe that's because they've gotten used to that, that's how they now define themselves, that's what they've learned to tolerate, not because it's what they think is a good quality of life. So just another little twist to think about here. When a patient will inevitably die, how good a job are we doing in ensuring that they have a good quality death and that we manage their symptoms effectively and that we manage the family dynamics effectively? And I would submit to you that currently we still do a pretty miserable job there, and we have a lot of opportunities for improvement in that realm as well. When we think about suffering, if we only limit it to the child and we don't count the 488 average number of invasive procedures that a child endures, not including turning and suctioning, during their NICU stay, we also have to look at the parents. And what the parent anticipates when she's pregnant and he's expecting his wife's delivery is that they're going home to that beautiful yellow and blue nursery. And what they're confronted with instead, in the case of a NICU patient, is the image next to that, which is a foreign environment. People do not understand where they are, and Latrette has done some beautiful work about PTSD in the relatives of ICU patients, regardless of the final outcome of the patient. And it's a 70% incidence, which is dramatically reduced by giving them an orientation to the ICU and explaining what's going on, what these pieces of equipment are. But in any event, suffering absolutely happens just because you've walked into an ICU. Again, parents are expecting to be nursing and loving their child at home, and instead they see a child who is filled with tubes and wires, and this represents suffering as well. Well, why am I interested as a pediatric critical care physician in NICU palliative care? Partly because I get a lot of the products of the NICU into the PICU, but also because half of the deaths every year in the United States are represented by neonates. The vast majority of deaths among children in the United States and Canada die within the first month of life, and then within the first year is the 50% of the deaths. So moving on to what is palliative care and how is it different from what you think it is, perhaps. It is the active total care of patients and their families. So by definition, the paradigm is different within palliative care, that we don't only focus on the child, that we do focus on the well-being of the family unit, that we address not only the physical, so all these outcome measures that John skipped about living and dying and what does the gray zone look like. We go beyond that. We worry about the psychosocial impact of the health and illness, the emotional impact, spiritual concerns, all associated with the illness. And therefore, it's an interdisciplinary sport. Unlike most medicine, which is multidisciplinary, which means that you write your note and I ignore it, and I write my note and you ignore it. We actually do interdisciplinary, which means that we sit down and talk with each other, we respect each other's input, and we use that to create a whole treatment plan that incorporates all of the elements of the patient and family's best interests and well-being. And so we collaborate with each other. In fact, we've actually gone to the word transdisciplinary, which means that I, as the physician, might be in someone's house and they bring up a spiritual concern and I address it with them, and then I report back to my chaplain that maybe these are some things that you ought to follow up on. So that's transdisciplinary, not being in your own silo. And our goal is to achieve the best quality of life for the patients and their families. And this is applicable throughout the course of intervention. And it can be concurrent with efforts to prolong life. So who are some of the fetuses and neonates and families that might benefit from palliative care, neonatal, perinatal palliative care? Patients who are delivered at the limits of viability. So again, it's not to say that you're going to or not going to use ICU interventions. Notice I didn't say life-sustaining medical treatment. It doesn't mean that you are or are not going to do CPR. It only means that you're there to address suffering and to walk with these families as they make the decisions, as they see the events unfold, as they determine what will ultimately be the final decision about the goals of medical intervention. So by calling palliative care, you're not calling in the death squad. I do not have wings on my back. I don't have a tail growing out. I don't have horns coming out of my head. I am there to help you help these families do some of the things that take a lot of time, a lot of hand-holding, a lot of discussion, a lot of repeating things, a lot of asking more questions. I am not there to predetermine that this child is going to die or what medical interventions will or will not be used. Presence of life-threatening anomalies, overwhelming illness not responding to disease-directed intervention, chronic or life-limiting conditions, uncertain outcomes, potential for severe disability, and the very large number of families who survive the stillbirth of their fetus or newborn. I'm not going to give you a lot of data slides because I'm not sure they're all that helpful, but I will say that despite the fact that we have achieved much better outcomes due to the bravery of families and physicians and others that work in neonatal intensive care settings, it looks like we may have hit the limit as to how far we can push, that we may be at that edge of that envelope that everybody's always want to make different, and that now what we're doing is prolonging the dying process. The numbers aren't changing, but the duration of time in the ICU is changing for these patients. And I think I'm gonna skip this one too. So suffering is when the burden outweighs the benefit, and this is not dependent on your decision about the benefit. It really is the families that take these kids home or live with the fact that their child has been buried that we have to be concentrating on. And so the gray zone may not be defined by numbers and statistics. It may be defined by values. Uncertainty is really hard for families to cope with, and sometimes walking with them as well as trying to limit the uncertainty that isn't actually there can be helpful. And sometimes it's difficult to identify who's a good palliative care patient. But I love Eric Cassell's quote about suffering and the limits of medicine. And he said, the relief of suffering and the cure of disease must be seen as the twin obligations of a medical profession that is truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. And that's really what we want to try to avoid. So what are our roles as physicians and other healthcare providers in providing medical care? We need to understand what the diagnosis is, make our best estimate of prognosis, determine all medically appropriate, relevant, and legally and ethically acceptable options and explain them. So when you have a hypoplastic left heart, not describing palliative care probably isn't appropriate, okay? And maybe talking about VSDs in the setting of trisomy 18 may be appropriate, all right? So we're going with our ethical relativism and all that kind of good stuff. And elicit the family philosophy and overall goals. And again, sometimes words don't get there. Sometimes we need to show them videos. Sometimes we need to have them visit with other families and see what it's really like when you bring one of these kids home. We have to help them to look at these choices through the lens of their priorities and make recommendations in that context for the goals of care. And again, we need to ensure that the interdisciplinary care team is present. I love it when, especially oncologists, talk about response to treatment. But what they're defining as response may not be at all what the family understands they're hearing. So it doesn't mean cure. It may mean that the tumor shrunk 10%, but we're not disclosing that. So when we do talk with families, we need to be totally transparent in how we're describing what the potential outcomes are. And that we should focus not only on the short term, but on the long term, because that's what they're going to live with, not just what happens in your ICU. They're going to be focusing on what happens to them the rest of their lives. When we do have these kinds of conversations with families, it's really important that we disclose our own personal biases. And I know some people don't like the idea of families asking, well, what would you do, doctor? Or what would you do, nurse? Or what would you do, respiratory therapist? But I always answer that question after I say, look, I'm not you. And you and I may not see the world through the same lens. I have a totally different job than you. I grew up different than you. And for me, and then I explain my bias, and then I say, but what I understand about you is this. And so therefore, this is what I think you might want to do. But let's talk about that further. So the things that go into making a decision are the facts. Those are critically important. But values probably weigh in much more than we like to admit. Interesting series of articles that Alex Cohn sent me about hypoplastic left heart decision making and how physicians would decide differently within their own families if they were confronted with that fetal diagnosis or newborn diagnosis versus how they counsel families. Well, why is that? Maybe they don't think they could tolerate having a child who's chronically disabled. Maybe they don't think that their wife could tolerate having a child who's in and out of the hospital all the time. But they're going to tell other families that it's okay, that you can learn how to live with this. Okay, so I think that's really interesting, that we might counsel people differently than we would act for ourselves. Again, looking at the idea of values. Effect on others is an important thing. We cannot look at best interests in isolation, even though theoretically that's a great idea. It just doesn't work that way. We need to talk about the alternatives and how they may factor into your set of values. And perceptions of respect and empathy. I'll relate a very quick adult scenario for you that I had. I had a 77-year-old ESRD patient who had had a huge hemorrhagic stroke, was breathing about 2 to 3 times a minute off the ventilator, ended up with severe sepsis syndrome on the ventilator, not responsive to treatment. And his wife of 20 years, who had been in the gutter until her preacher husband had pulled her out and put her on a pedestal and made her breakfast in bed every day for the last 20 years, was asked, do you want, listen to these words, do you want to take your husband off life support treatment? Really? So she didn't feel like anybody saw her husband. She didn't feel like anybody saw her relationship with him. She didn't feel respect. She didn't feel empathy. She just felt like people were pushing her to do something that was morally reprehensible to her. But if instead you said, I see that you love your husband very much, and I know that he loved you too, and I know he's a hero to the people in his congregation, and I also know that he's going to die no matter what we do, so how can we appropriately celebrate his life? You go from somebody who's running out of the room screaming, how dare you, I hate you, leave me alone, leave my husband alone, to someone who says, thank you for seeing us. And yes, we'll take him off in 2 days. Okay? So we need to recognize that relationships and the way that we talk about them are virtually everything in end-of-life decision-making and palliative care. The AAP came out recently with a new policy on non-initiation or withdrawal of intensive care from the high-risk newborn, and gave some guidance, including not to coerce families and to not offer treatment that's not beneficial. But again, over time, I think I've really noticed how much the words that we use influence the decision-making process. So firstly, to clear up the confusion, palliative care is not hospice, and it's not dying. Palliative care is about the prevention and relief of suffering. And death has always represented failure to the people who were trained in my era of healthcare training. There was very little about quality of life during the time that we were growing up in the medical literature, and so we have not learned to really value that completely. There's inadequate palliative care training of providers and a focus on, quote, life-prolonging interventions and not providing care. And there's inadequate evidence base. This is the concept that I am fighting against constantly, that there seems to be this cliff that people think that we come up to and we jump off of. And when we jump off like that, we abandon our patients and families oftentimes from a decisional standpoint. They feel like we've walked away from them, that we don't care about them. And this happens most when we talk about the idea of withdrawing treatment, withdrawing care. I provide intensive care to my patients that have palliative needs. I treat them aggressively for distress, whether it's pain, whether it's emotional distress, whether it's spiritual concerns. I am an intensive care physician, although I don't work in an intensive care unit any longer. And until we get that, we're not going to be able to really offer palliative care. This is what palliative care is supposed to look like. It starts at diagnosis, and its emphasis in the disease treatment plan or the care treatment plan changes depending on whether or not the patient is responding to medical intervention. So the word curative is rarely appropriate in medicine, and we need to get away from that term as well. We do disease-directed treatment, we do disease-modifying treatments, and hopefully we do suffering-modifying treatments as well. So in responding to the uncertainty that's inevitable in the neonatal intensive care unit, we need to maintain realism and hope at the same time. Families really need hope, but that doesn't mean that they want to be misled. They can tolerate honesty. We need to provide intensive pain and symptom management, to look at the condition as a whole, not, well, I can fix your kidneys or I can fix your lungs, but who is this child and where does he fit in the family? To evaluate the benefits and burdens of treatments, and to, most importantly, affirm parents' efforts and love for their child, regardless of what the decision is that's being made. Parents want to be treated as partners in the decision-making process. They want to be seen as parents of their children. I remember very clearly when I was a resident, we had parents that didn't have a place to sit in the NICU, that weren't welcomed there, that were rarely called spontaneously, and that over time began to feel like the child didn't belong to them. The nurses even bought the children clothes and toys and felt like they were providing the best care possible because after all, they were their children, but they're not. Okay, so we need to keep the parents involved and welcome them. They don't want to be treated as visitors. They don't like the idea of the term visiting hours. They are the parent of the child. And the more continuity of care they get and the more that they're seen as the parent of the child, the less hypervigilance you'll see them having because they trust the bedside caregiver. They need more parent-to-parent networking. So getting back to the word issue, do you want us to do everything possible? Well, with what goal in mind? You know, to limit suffering as much as possible, to extend the life no matter how much suffering there is or what the quality of life might be. Will you agree to discontinue care? The answer is no, regardless of what you're talking about at that point. Okay. It's your decision. Well, they're not ready for that. They don't have the information. They don't have the emotional fortitude. They don't want to be saddled with a decision that they are making in a foreign environment about a foreign set of issues. We should stop aggressive care. Again, if I'm dyspneic, I want aggressive care for my dyspnea. We're going to stop curative treatment. Well, can you cure prematurity? I haven't seen it. We're going to stop treatment. Well, I want treatment for my pain. And we're going to stop support. If my child's dying, if I am dying, whether I'm a neonate or an older person, I need support. Okay? So these words are a real problem. And we need to think about different ways of talking about it. I used to talk about non-beneficial treatments, but as I reflected on that, I thought to myself, as a parent, I would think, well, maybe they were experimenting on my child because they were doing non-beneficial treatments. Or maybe they were doing things just to make a lot of money, because after all, ICUs generate a lot of money, right? So maybe they're doing non-beneficial treatments so they get more reimbursement. So now my idea is, and although it's a mouthful, I'd really like to talk about no longer beneficial medical interventions, which implies the time-limited trial of, you know, we need to give them the best shot at the best outcome by doing all the things that might help from the beginning. And then after we've seen how the child responds to treatment, then we can reevaluate whether or not this is continuing to be beneficial or it's no longer beneficial. So I like those words. It's too much, it's too long, but I haven't found a better way of saying it. Sometimes we don't mean to say something that we are saying. When we say that he's stable, maybe it means that we haven't changed the ventilator settings or the pressors recently, but to a family that means that he's getting better and going to be discharged soon. Okay, that's a therapeutic misconception happening there a little bit. She's gained weight. Well, if you're a CHF patient, that's not a good thing. But for most babies, it's a great thing. So maybe we're misleading people that way. Do you want us to do CPR? Implies that it might work. And in the cases in which we're asking, usually it won't. Or do you want us to trach him? And families have no idea what that translates to. It translates to being up all night, suctioning, being totally dependent on somebody showing up at your house. It's a life-changing intervention, and we don't do good informed consent about that. So what are some helpful ways of talking about these things? I wish things were different. I hope he gets better too, but I think it's very unlikely. We've tried everything that might help, and unfortunately, he's too sick to respond. Notice I didn't say he failed treatment, okay? And perhaps we need to consider alternative goals of care. Parents often blame themselves, especially the mother-in-law blames the wife, right? And they need to know that they didn't do anything wrong to make this happen. There were no medications, no illnesses or activities or thoughts that could have caused this. A lot of times people didn't want to get pregnant, and then their kid has a problem, and they know that it's because they didn't want to be pregnant that the child has the problem. So disabusing them of some of those magical thinking notions is really, really important. So we need to give accurate information. And again, this birthing plan idea is further detailed in your handout, so I'm not going to talk about it. Again, stopping no longer beneficial medical interventions may be better language. And this little guy was a 24-weeker who had a bilateral grade 4 interventricular hemorrhage at day of life 3. His parents were not informed because I live in Texas. And they thought that they had to keep doing everything possible regardless of the parents' perceptions of benefit. And at 5 weeks, the child had a non-communicating hydrocephalus, severe BPD, and was physiologically unstable on maximum ICU therapy. Once they finally fought effectively for their rights to make a decision about the best interest of their child, they made the decision to forego further no longer beneficial ICU medical interventions. And this was the first time the child was still on a MinStem protocol. This is the first time at the age of 5 weeks that the mother ever touched her son. His heart rate went from 180, and he was gray at 180 to 140, and he became pink. This is the first time that his 15-month-old, former 30-week preemie brother ever got to be with him, and the parents were parents of disabled, or teachers of disabled children. They were 40, and this was their last chance. The mother had had a hysterectomy at the time of delivery. And they made the decision to extubate in a loving, spiritual, family-centered way. When we do these sorts of things, when we discontinue no longer beneficial medical interventions, we need to make sure that patients have time to ensure their supporters, that they plan for their celebrations and rituals, that they have unlimited visitation, that we reaffirm the decisions before we remove the devices, and that we reassure them that nothing else will work. We need to tell them what it's going to look like and what we're going to do to limit suffering. And I like to make 3D hand molds so that they'll always have their hand to hold. Then we need to make sure that we're not doing labs. We take away the monitors so they don't beep. We stop doing vital signs. They're not helping us. They're not helping influence decisions. Stop doing weights. Stop doing IV fluids and feeds because we don't want the child to gurgle. Antibiotics and other treatments that are not directed at the patient's comfort. Remove any medical devices that are not needed because we want the child to look like a child, not a patient. And invite them to bathe the child, change their clothes, take photos, hold them, or do whatever they want, and move them to a private family-centered location. Of course, we don't want to have any paralytics on board for days before this all happens. And there's a debate about pre-bolusing versus treating dyspnea as it happens. My bias is to wait till it happens because it doesn't always happen, and a lot of times the patient is just apneic when we take the tube out, and we don't want any perceptions that we have hastened death in any way. I'll end with this quote: as sickness progresses towards death, measures to minimize suffering should be intensified. Dying patients require palliative care of an intensity that rivals even that of, quote, curative efforts. Even though, quote, aggressive curative techniques are no longer indicated, professionals and families are still called on to use intensive measures, extreme responsibility, extraordinary sensitivity, and heroic compassion. Thank you.